I'm Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia, and welcome to Psychotherapy and Applied Psychology, where we explore practical insights with leading experts. Today, I could be more excited to welcome the world's authority on mental health diagnoses. While having this conversation, I was so inspired by how my guest and his colleagues developed a grassroots and scientifically based movement for changing how we do diagnoses. In this conversation, you'll learn about the HiTOP model, which is what psychiatric diagnoses would look like if they were based on science. Please leave a comment below, and if you like this conversation, it'd be appreciated if you hit the like button and subscribe to the channel. This episode starts with my guest responding to my question, what's wrong with the DSM? So without further ado, it is my pleasure to welcome my very special guest, Dr. Bob Krueger.
What's wrong with the DSM? Where to start? So the DSM, as I think many listeners will appreciate, consists of literally hundreds of putatively categorical psychiatric diagnoses, right? And it stems from a kind of a paradigm, right? Like a way of thinking about the world and a way of approaching psychiatric diagnosis that's embedded really in, 19th century medicine. So if you think about like the origins of scientific medicine and the way in which concepts in medicine were originally generated, they relied pretty heavily on clinical observation, right? So the start of any medical intuition about a diagnostic concept is the experience of physicians working with patients, noticing that certain patients share certain kinds of features, right? And that on the basis of those shared features, one might characterize the phenotype, like the clinical presentation of a certain kind of class of individuals. And then with that kind of being laid out, right? Like we tend to encounter people for whom these things are present, right? In terms of clinical signs and symptoms. That's when the scientific process comes into play, right? So you have a pretty good description of the clinical phenotype, like what people with a certain kind of set of characteristics look like in a clinic. And then, right, you can apply modern scientific methods to try to understand what the etiology, like the underlying cause, and the pathophysiology, like current, physiological correlates, right, of that category might be. And, for a lot of medicine, this kind of paradigm, right, this approach has worked reasonably well for a number of different things like infectious diseases. And probably the reason, right, that this approach kind of works for a lot of things is because the etiology and the pathophysiology, I don't want to call them simple, but are sort of straightforward. Like if there's a pathogen, right, it's going to interfere with certain key biological processes. Many pathogens can be seen under a microscope, right? So you can see that they're there, and they're not there for comparison, participants in some kind of study. And so the paradigm kind of works for a lot of things. And I think what we face now, broadly in medicine, and definitely in it's like psychiatry and clinical psychology, is kind of the residual, like what's left after we've kind of figured out some of that more straightforward stuff. So, like a lot of late life medical disorders are complicated in terms of their etiology. Many different genes are involved, many different environmental exposures are involved, and it's hard to characterize a singular, kind of cause. And for these psychiatric kinds of things, that's almost certainly true, based on a pretty substantial literature, right? That psychiatric conditions are not simple in terms of their causes, in terms of their pathophysiology, like what you could observe using scientific means for characterizing biological correlates. And they combine not just kind of, call them, for ease of, communication, like biological, distal, like faraway causes, like genomic variants. It also combines that with a bunch of experiences that people have in their lives. All this being mediated through the brain, which is the most complex organ, a considerable amount. So you have kind of this conflict between a paradigm that worked well and that's traditional in medicine, where things get classified into these categories, and the reality of human variation, which is much more multifaceted, complex. And that's, I think, the basic fundamental issue, right? The DSM continues to be wedded to a kind of descriptive paradigm that originates again from 19th century medicine, whereas the science has shown us that that's not really a very good account of the way in which causes, ultimate causes, kind of lead to human suffering of a psychological nature. So then the question is like, well, what are you going to do? Right? And the issue with the DSM is it's kind of persisted with this approach because it's traditional, it's well understood, it's embedded in all of our textbooks, it's embedded in residency training programs, it's embedded in psychology doctoral programs. Like, it's just part of the fabric of these disciplines. And so how are you going to proceed, right, given this emerging knowledge of how complex, these etiology type things are going to be? So that I think, when I think about it, that's the fundamental issue, right? The DSM is wedded to an approach that worked well for a lot of things and isn't working well for understanding psychiatric conditions. So some new approach to describing clinical presentations, might work better.
And I love the example that you gave right at the beginning of that, of the pathogen, which is immediately outside of anything I know anything about. But the idea of you have the pathogen or you don't have the pathogen, right? It's an on-off switch.
Yeah.
And so in that context, in a diagnostic context, it makes sense to have a category. Does she have it? Does she not have it? Right?
Yeah.
But when it comes to psychiatric disorders, that it just doesn't work that way. And I think about, during my training and just sort of generally in the field, there's kind of this, people kind of laugh about the idea of a patient having a single disorder. That doesn't really, once you really understand the DSM, the diagnostic classifications, and have a really strong sense of it, sort of once you've been doing it for a little while, and you start seeing a bunch of, you start to have a certain number of patients where you start to have seen a bunch of different presentations of these symptoms and that sort of thing, you start to realize, nobody has just one thing. There's a bunch of stuff going on, which is a critique in our field when we come to treatment stuff, which we'll talk about a little bit later on, but because oftentimes our treatments are designed for a specific disorder and with no, what we'd probably call comorbidities. But it just that I think for any clinician or even person in training who's a little while along, it becomes pretty clear relatively early on that these things are not just on-off switches that have nothing to do with one another.
Right. Yeah. No, and I appreciate you bringing it back to, the clinical realities, because that's where a lot of this started for me, right? So I'm a clinical psychologist by training, more involved in research than in clinical work these days, but not zero involvement in clinical work. I'm just kind of busy with my academic job. But it all kind of started with that, right? It started with wanting to be a good diagnostician, wanting to understand the concepts that are in the DSM. I wanted to do a good job in the clinic of characterizing presentations. And then just finding it frustrating to see the extent to which the basic sort of differential diagnosis approach didn't really work for a lot of presentations. Because the idea, right, is, okay, choose the best single categorical label. Sometimes that might be confusing because other things might be present, but your job is to try to figure out the best single label, and finding like the presentations didn't fit well with that approach because there were always other nuances, right, and other complications. And in a categorical diagnostic system, as you mentioned, the only way to really handle that is to say there's a bunch of comorbid conditions. And that doesn't necessarily work well either, because then like how do you pick a primary and how do you characterize the secondary? And then the other thing I think that one finds in clinical practice is one uses things like the DSM and really the ICD codes that correspond to it, at least in the United States, right? Those are the codes that you use when you're dealing with a third-party payer, right? Because you got to put something into the record. That's an administrative matter for a lot of clinicians, right? You got to do it, and you're supposed to be familiar with that nosology because that's how you're justifying your professional activities in the clinic. But then, in terms of case conceptualization, people go in 100 other different directions, right? I don't think typical clinicians are super wedded to this person has panic disorder with agoraphobia. That's it. Like nothing else here is relevant. I have this manual on my shelf for what to do, and in it's a kind of slavish manner, you like go through the treatment manual. I just don't think most seasoned, sensitive, effective clinicians are doing that, and so that's another kind of disjunction that you discover, in the clinic. That, okay, we have to kind of deal with these things for administrative purposes, but for case conceptualization purposes, and really for like effective psychotherapy, people are bringing in a host of other bits of information, approaches, skills, techniques, right, that are naturally connected with a much more nuanced way of thinking about the person and their presentation.
Yeah, I think if you have any, when you talk to full-time practitioners, it seems like the idea of this person has this one specific disorder and really solely attending to that disorder is going to help them live the life they want to live. And that's going to be the sole focus of treatment. That's the outlier. Like, it's not that it never exists.
Yeah, that's
right.
fair.
But it's once a year or two. I mean, it's, it's so uncommon that the idea of basing our way of thinking and working with clients on that is ridiculous.
Limiting, at the very least, and out of sync with a lot of presentations. I mean, you're right. Sometimes you might encounter someone who really has a specific phobia or something like this.
Right.
But
that's so rare.
Issue. Or they come in with, and see, oftentimes these cases are milder, right? Like a specific thing happened in their life, and now they're depressed, and that's really kind of it. And it was very like something happened, right? And they've never really experienced serious episodes of depression before, and that can be kind of focal, and you can kind of be effective. Thinking about this is fairly specific, but in my experience, at least, and probably others too, like that's rarer, and it's often a simpler presentation of less severity, right? Such that many people that we encounter have a much more shifting, fluid, complex life history and set of presentations, right? So that it's hard to conceptualize it as something happened and now the person's functioning rather differently, and I can really hone in on some specific diagnostic construct to guide the intervention.
So as in sort of a way forward, a way that's guided by the science, and I mean, and frankly, by the practitioner experience as well.
Yeah.
You and your colleagues started the HiTOP model. So what I'm curious about is how that got started broadly, and also what some of those conversations were like with your collaborators.
Yeah. HiTOP started around 2015, 2016, somewhere in there. A number of people had been kind of publishing on patterns of comorbidity among DSM disorders as kind of a toehold on trying to understand how you might evolve to a different kind of system. And in particular, there are two other people that I need to mention. That's Roman Kotov and David Watson. If you look at the history of HiTOP, it's fair to say that the three of us were kind of the founders. And really, Roman, in a lot of ways, is the engine behind a lot of this stuff. The person who catalyzed all of this, right, and said, look, different people are kind of publishing on similar ideas. They're sort of doing it within their own lab or work group and coming up with similar and related kind of conceptualizations based on the data. So would it be viable to assemble a consortium, right? Like a group of people who are taking similar approaches with the goal of working on some of these limitations of DSM style approaches in a consortium manner, right? Like working together, linking a lot of people together. And so, to be honest, my initial reaction to that is it would be hard because of how academics works, right? So there's a lot of herding of cats type of thing that happens in those circumstances. A colleague once told me that, approaches, right, like, or the way you think about the world are kind of like, or models even, right, like, are like toothbrushes, right? Everybody's got one, they don't want to use somebody else's, right? So right, the challenge there, I think, was like, could you get people enough on the same page to see the bigger picture and the advantages of working on this collaboratively, versus working on it more sort of competitively or focusing on somewhat narrow differences among different approaches and conceptualizations to see like the advantages of a big picture and some of the advantages of pulling this all under a rubric, a title, a consortium, a concept. And it's really the Romans' credit, really. Like I wanted to be involved rather than not involved, right? That was clear to me from the beginning, because it's exciting and fun to think that such a thing might even be possible. But I got to give a lot of credit to Roman for like doing a lot of the hard work of pulling people together, getting them on the same page, right? He led, and I played a pretty substantial role in it, but he was the first author on the very first consortium publication. That's the 2017, HiTOP paper that's often cited as the origin of the approach. And that's been very gratifying, I think is the word I want to use, right? To see that we could do this, right? That there was enough interest among a diversity of colleagues with a diversity of views in trying to get a kind of unified approach together that provides an empirically based alternative to the traditional DSM categorical classification from this kind of grassroots movement, right? So HiTOP's never been connected with or attached to a particular authoritative body, right? So, the DSM is published by the American Psychiatric Association, so has the full weight and financial resources and everything that comes from that kind of connection. Another alternative we might talk about at some point is the RDoC approach. That's an alternative to the DSM that the National Institute of Mental Health has promoted. And I mention it in this context because it's another viable and I think in many ways successful alternative to the DSM, but it's connected with the NIMH. So it has these auspices under which it functions. HiTOP is a grassroots movement by contrast, right? It's academics and many clinicians getting together in a grassroots kind of way to kind of propose an alternative. So does that I think that addresses your question, right? Like, where did this all come from, right? It came from that, and then it grew from there, right? It turned into a pretty substantial consortium. There's hundreds of members now, many different work groups that are very active on different elements of the kind of intellectual space in which, psychological diagnosis is sitting, right? So there's a genomics work group and a neuroscience work group and a clinical applications work group and these kinds of things, right? So it's grown from a few people interested in trying to make it happen to many people wanting to be part of the party, basically, right? And engaged with the endeavor.
Yeah, and I think you very much hit on what I was struck by, because there's so much thoughtful infrastructure that you all have put around this. And as an outsider and looking at it all, I'm saying, how the hell did these people do this? Not that it's impossible, but that, like, just like you're saying, to an extent, the academic grant getting, like, it doesn't prioritize or sort of reward what you all did. I mean, it seems like, it's rolling a boulder up a mountain. And then when you get to the top of the mountain and starts to go down the other side, then, there might be some benefit in the traditional ways you would think about, because you do have this huge sort of this machine theoretically that you can use to build and write grants and papers and do all these other collaborative, wonderful things. But just getting that going without being a part of a pre-existing, reasonably supported organization, I was
Yeah,
just
yeah,
rather like, damn, wow. I would have been the skeptic. I would have been the person who sort of said, yeah, this is a great idea in theory, but the amount of hoops and hurdles and challenges is we're going to be working on this thing for years before there's any potential benefit, and that, but likely it's going to get cut off before we even get there. And I was just sort of a little bit like, man, that was impressive that they got this thing going and we're so successful.
well, I appreciate you saying that. I think maybe part of the reason that was tractable or kind of happened that way is that people were looking for an alternative.
Right.
Right? In research, right, the DSM is pretty monumentally frustrating to try to work with because, again, like many presentations don't fit very well. So it's hard, I think, to do research that's constrained by the DSM paradigm. And, there wasn't really, what do I want to call this, like a descriptive alternative, right? Like a real target. HiTOP's not perfect or anything, but it does provide a target, right? Like here's an alternative. It has a name, right? There's these figures in our papers that kind of describe what the alternative looks like based on the existing data that can be, brought to bear on kind of like what would be the outlines of a viable empirically based alternative. So like that, I think that might be part of why that worked the way it did, is because there was a need. And the need is it's right the other way, as you're saying, like to fulfill a need like that is develop, Krueger's model or whatever, right? And then, like science is always this dialectic, I think, right? I suspect that historians of science, philosophers of science would back me up on this, between competition and cooperation, right? There are times when a certain degree of healthy competition can be motivating for a field because you've got people working within a paradigm to solve certain kinds of problems, trying to be the first to the finish line. But there are other times, and I think many modern areas of scientific inquiry look like this because of the complexity of the problems that are trying to be tackled, where the collaborative approach, right, really is the only way, because it requires leveraging a lot of people and resources and data to come together. So another area that I work in is genetics and genomics, and there that's very clear, right? Those scientific problems are sufficiently complex and multifaceted that it's been much more successful to create consortium type endeavors to make progress versus thinking that you're going to make some miraculous discovery, working on your own late at night in your lab. Right? It's kind of eureka moment. Has a certain sort of romanticism about it, right? And might play well in the movies, but like in reality, it's a lot of hard slogging and collecting a lot of data and working together in larger groups, right, to make real progress. And that's, I think, part of why HiTOP might have worked the way it did, and that people came together, is because it was a viable alternative, and people saw the desirable aspects of trying to cooperate under this umbrella. Because there wasn't really like an alternative to the DSM that had a name and a figure, right? And the kind of stuff that's in all those HiTOP publications.
So before we go much further, could you give us the overview of the HiTOP framework? And just as a reminder to the listener, so this is dealing with the problem of, we've treated these disorders as pretty much distinct categories, but the data, the reality doesn't line up with that. These things are much more complicated and much more covariate. They relate much more.
Yeah.
So give us the broad overview of the HiTOP model.
Sure, I can try to do that. And again, as we were discussing, right, there'll be some information in the show notes, some URLs, right, that people can look at to kind of get some visual representation of what I'm going to try to convey using words. But basically, there's two features that I could sort of highlight that make HiTOP distinctive from the DSM style approach. So again, the DSM style approach is to delineate a variety of categorical concepts for use in describing patients, where the idea is the concept applies or it doesn't, right? The diagnosis is reasonable to apply or not. And HiTOP is different from that in two key ways. There's the hierarchical aspect of it, right? So that's sitting in the name, right? The Hierarchical Taxonomy of Psychopathology, HiTOP. And it's dimensional, right? So it doesn't impose categorical distinctions where those distinctions might not exist in nature. So going through those two things, right, HiTOP concepts are organized from very broad and general, right? So they summarize a lot of information about people, the broader and more general concepts, to very, very specific. So I think we can talk about sort of three big spectrums of psychopathology. So HiTOP really invokes this notion of a spectrum, right? That's meant to get at the idea that some things have certain things in common and also certain things that are distinctive, right? That's the hierarchical aspect, right? Whereas at the higher levels of the hierarchy, we're characterizing features that different, people have in common at a broad level. At the lower levels, we're talking about very fine-grained distinctions among different specific patient presentations. But anyway, at maybe like close to the broadest level are these three big spectrums, right? Internalizing, which is problems with mood and anxiety, and basically the experience of negative emotions. Externalizing, right, which is problems that people have when they act out, and they create problems for society at large or other people in their lives. And sort of kind of psychosis spectrum, which is difficulties with cognition, essentially, right, with reality testing. And so at a broad level, all the stuff, right, that's described in something like the DSM kind of falls into those three big bins, right, of internalizing, externalizing, and psychotic problems. And the dimensional part is HiTOP, recognizes that there's a substantial scientific literature showing that these thresholds that are set in something like the DSM are arbitrary, right? So there's no compelling scientific basis for a lot of the thresholds that are in the DSM. Oftentimes they're set as just more than half of the criteria, right? So a typical setup in the DSM is there's 9 criteria and you qualify if you have 5. And 5 is the threshold because it's more than half of 9, not because there's any evidence for some kind of like cusp.
Is that really the reason?
Yeah, as far as I know, right?
That's hilarious.
I mean, yeah, I can say that with pretty good confidence in the personality disorders area because that's mostly where I contributed to the previous DSM, which we talked about in our previous conversation about the alternative model of personality disorders. There, I'm pretty confident in saying that there was no real basis for those thresholds other than that it's around half or slightly more than half of the criteria needing to be present. And that's not a compelling scientific basis for claiming that these things are categories. So anyway, getting back to HiTOP, right, these things are considered dimensional, and that much better fits the data. Right, that people might have these features to different degrees, and there are differences in degree and not so much in kind. And also then when you think about case conceptualization, you're talking about a profile of qualities that a person has, not the presence or absence of a specific diagnosis. So just making it simple with these 3 broad spectrums, any given patient could be characterized by some mix of those or one being more primary. And that helps with all the complicated comorbidity, exclusionary rule stuff that's always been awkward in the DSM setup. So to pick a really specific example that you often see clinically, many people present with psychotic types of problems. Some of them, many of them, have various kinds of mood disturbances that vary in time-varying ways with their, psychotic coming in and out of psychotic episodes, right? And is the mood antedating the psychosis? Is it entirely there with the psychosis? Does it have, bipolar type features, by which I mean, of course, mania or elevated mood, right? That all gets handled in the DSM by saying, well, there's 50 different categories that you can put people into based on arbitrary distinctions about course and timing and stuff like that. The alternative is to think about this in a kind of more profile, dimensional kind of way and say, well, a person could be having a level of psychoticism that's pretty dramatic and not much, internalizing type disturbance. Another person might have a mix of those things. Some people will present without externalizing features, right, which often have to do with substance use and antisocial behavior and things like this. Some people do present with that. So instead of okay, we need to figure out the right categorical label from among the hundreds that are sort of possible here, based on relatively arbitrary rules about course. And then, to make that course stuff make sense, you'd have to sort of trust the patient as a historian. That brings up challenges too. Like how easy is it to get from a person has some, thought disorder type characteristics, the exact nature of the disturbance over the last 10 years or something like that. That's hard clinically, right? Instead, the idea here is, okay, we'll come up with a dimensional profile, and we can use that to describe the patient's presentation and to frame our intervention efforts. And then I'll just, add another piece, because people often ask about this because it's a logical thing to wonder about next. Well, then how do you decide how to intervene, right? One of the traditional putative advantages of categories is, they have the diagnosis. Here's the book that describes the treatment for the diagnosis. What are you talking about in terms of intervening on a profile or intervening on a dimension? And I think that's a matter, we have a clinical translation work group, right, in HiTOP that's really kind of articulated this in ways that I think are very useful. But it's basically a matter of taking strategies and things that exist, right, in the existing psychotherapy and psychopharmacologic literatures, right, and applying them to what are some of the most acute things, what can we do about them, in a pretty, traditional kind of way. It's just they're not tethered necessarily to arbitrary categories. They're tethered to the current presentation and what might be helpful. And I think there's evidence that that's what people do kind of anyway. I haven't spent a lot of time in clinical settings where people kind of aren't thinking like this, because it wouldn't make a lot of sense. By which I mean, I don't have a lot of experience with people being really wedded to the categories. It's more like, well, what is the person, complaining about or suffering from right now? We have these interventions to help with that. And not a lot of concern with, well, we can't do anything about their mood problems because mood is excluded if thought disorder is present or something like this, right? It's more like, well, we have these things, right, that can help with thought disorder type problems. We have these things that can help with mood type problems. We'll somehow, meld these things together to come up with a treatment plan, if that makes sense. I think that's kind of how people function anyway, is my point. Just HiTOP maybe is closer to the way in which clinical case formulation works intuitively. It is kind of my, I guess, assertion here.
So the idea is, in the way the DSM is organized now is you basically have a bunch of different, and you might know how many it is, about a dozen-ish chapters. I don't know if they're even called chapters, sections that are sort of divided by type of disorder or something like that. And so what HiTOP is saying is that there are these 3 spectra that seem to work out pretty well in terms of organizing psychopathology. So this internalizing, externalizing, and psychosis, or I think what you all call it is thought disorder. But I think we can all think of that generally synonymously. Generally, I'm sure we're missing some of the nuance there. Right. Yeah. So you have these 3 broad spectra that that psychopathology tends to organize itself within. And then you have then what falls underneath of that?
Right. So that's a good point. That's the hierarchical organization. And again, this is easier to see visually and somewhat more challenging to describe just using words. But we can pick these specific spectra and talk about how they fall out in terms of more fine-grained distinctions. So let's pick externalizing as an example, right? There are two things that kind of come within the realm of externalizing, roughly speaking. One is more like a disinhibitory tendency, right? So kind of like acting on the spur of the moment and kind of being driven by immediate rewards rather than thinking about future consequences. So a disinhibitory variant of externalizing. And the other variant is a more antagonistic variant of externalizing. So doing things that are hostile, hurting other people on purpose, acting out in angry and obstinate ways, right? So within externalizing, there are these two sort of sub-spectrums. One is more disinhibitory and one is more antagonistic. And then you can go down further, right, in these things and get into very fine-grained personality concepts and symptom clusters, essentially, right, as you move down the hierarchy. So it's kind of a bandwidth fidelity situation, right? So by bandwidth, I mean the broader constructs, like have a lot of bandwidth, like they're conveying a lot of information with one variable. And fidelity is at lower levels of the hierarchy where you need many more variables to convey the same information. So that's something that, the clinician can think about, right? Is there some utility in a much broader label, or is there some utility in very fine-grained things? And that's going to vary based on the presentation as to, and really for the scientific purposes too, that you're kind of studying things like, if you use this kind of HiTOP approach, you can figure out where something is located within the hierarchy. If you have a biological correlate you're interested in, for example, does it relate to a broad spectrum? Does it relate to a specific symptom cluster? Right, that becomes much less frustrating, that kind of science, I believe. Right, it becomes much less frustrating because you're casting these correlates within the hierarchy and not trying to figure out, like based on arbitrary categories where it falls, because that literature often leads to the conclusion that there are similar correlates, to diverse disorders, not to mention all the interpretive stuff with like, what do we mean by that? How did people get into those disorder groups? How arbitrary was that? What did the investigators do about comorbidity? Stuff like this.
I think that the example that
it's easier again to see this visually, right? And I hope people will sort of turn to those figures, but I'm trying here using words to talk about like very broad spectrums, right, are part of the model at a high level, and much finer grained concepts, right, are part of the model at a lower level. And the key scientific piece of this is that our organization fits the data, which I think is the most attractive thing from a scientific perspective about how HiTOP works. It's not somebody in their armchair, right, kind of trying to say, like, I think it might work like this, right? Rather, there's a lot of data that speak to the organization of psychopathological signs and symptoms as having this patterning, right, that I'm referring to here. Right, so when I say, roughly there's internalizing, externalizing, and psychosis, there's just a lot of data that says, okay, that's how natural patterns of variation in psychopathology tend to fall out. Or when I'm saying within externalizing, there tend to be more disinhibitory and more antagonistic aspects, that's how that literature looks, right? You take the whole set of things that people have come up with for assessing externalizing problems and ask, kind of how does that stuff go together in nature? Well, that's what you find, right? There are kind of more disinhibitory aspects and more antagonistic aspects. So what I'm describing here has a basis in reality, right? And actually a pretty substantial scientific literature that leads to, the kind of HiTOP model that's been described in all those papers that we've,
Well, I think that the example that you gave of disinhibition and antagonism is a great one because it immediately helps the person in the field. To make sense of why is this person doing this, or like what like the important stuff, right? So is it that this person is this person in jail because they just sort of can't stop themselves from, whatever their impulses are, right? They're just sort of going, right? I just can't stop myself, right? So that's sort of that disinhibition. They can't just, they're going to versus the antagonistic person who's in jail, who's there because they, at the most extreme example, want to do harm to others or something like that. And those are right. That's both those people, right? These are folks who are more likely to get in trouble in school, in class, and then, with the criminal justice system and all that sort of stuff. But those are really important differences. And it's very clinically meaningful in terms of what am I going to do to try to help this person?
Yeah, I think that makes sense. Yeah, I think that, well, I mean, again, like that fits the data. And I think the way you're describing it is a useful way of characterizing, why you want to understand the personality, essentially, right, of a person that you're dealing with. So that's another thing we haven't really talked about explicitly yet, but part of the reason that HiTOP it looks the way it does is because personality really is kind of the infrastructure for psychopathological presentation.
Thanks so much for watching. If you found it helpful, please like the video and subscribe to the channel. I'll see you in the next video where we continue exploring the science of psychotherapy and applied psychology.